Welcome to another recap with Dr. Baker, who's been doing the clinical rounds on Tuesdays with our team. One of the things that has come up relatively frequently is questions surrounding our assessment process. We have roots in using the SFMA, or Selective Functional Movement Assessment, but I first want to just say that that is not the only thing that we are ever telling anybody to do, nor are we communicating to anybody that they should be doing the SFMA in its entirety. The SFMA is a great place to start. It has some great principles that are included within it. And I think at the end of the day, it is an appraisal of movement in separate areas. You're meeting an expectation for movement or you're not. You have something that's painful or it's not painful. And I think at the end of the day, we're trying to get to a point where after that assessment process, we have best ways to potentially insert ourselves based on the information that we've aggregated over the course of that assessment process. So I know I just kind of gave everybody a 10,000 foot view, but yeah, what do you have to add, Zach?
No, and I think that's how you look at it, is it is kind of a 10,000 foot view as to how we approach that initial encounter with a patient. And when I think of the SFMA and how it's commonly utilized in our setting, we're usually referencing what they'll call the top tier tests, which are just a head to toe assessment of how somebody moves. And the big take home messages that I get from utilizing this or any movement based assessment, no matter what model or process you're going off of, is you're bucketing it into two different areas of interest. Can they move in an expected way that you anticipated them to move? Meaning, can they get from point A to point B in the manner in which you expected it to be done? And that's pretty easy. It's black and white. Yes or no, they didn't. And then you can figure out, is that relevant or not to what's going on? How far do I need to go down this rabbit hole? Then you're looking at tolerance to that movement. So when we ask them to move in a certain manner that stresses certain areas of the body or requires certain positions or motions or activities to take place, do they tolerate it? Do they not tolerate it? Are they apprehensive? What is their overall ability to perform the movement and tolerate it? So ways that I think it's valuable, it's kind of a quick and easy way to see how somebody moves as a whole prior to going into your more traditional orthopedic exam or whatever specific activities you want to do to look at the problem they're actually coming in for, whether it be their elbow, whether it be their ankle, whether it be their neck or their shoulder. Things that I find really good value for this is it's a way to introduce movement to a patient that's not specific to what they're coming in for. So somebody's coming in and they're super focused on their elbow that hurts or their shoulder that hurts, and you lay them down on a table and start cranking on their arm, that may not be the best first interaction you have with them. So I think a lot of times it kind of breaks down the barriers to movement. You start having a conversation with them, you get them moving and doing stuff that they may be less apprehensive to doing. Then you can get more tunnel vision on the issue at hand. The other thing that I find almost more valuable than even like the diagnostics of it is it gives you a sense of what this individual's movement profile is. So I can't tell you how many times early in my career somebody would come in with ankle pain or hip pain. I do an assessment with them specific to that joint. As I'm getting information from the range of motion, the strength, whatever provocating test or special tests I'm doing, and I've got in my head all the things that I want to do for them. And then we go into the gym to start some sort of intervention or to build out a home program. And the first exercise I ask them to do, they say, oh, you know what? My back's been killing me for years. I've been able to bend over like that in 2 years. Or, oh, I forgot to tell you, I have this shoulder issue. I had a rotator cuff tear. I can't lift my arm that high. And you had this beautiful program in mind. You go into the gym and all of the things are appropriate for them to do for what they came in for, but they have these other issues you were unaware of that now make that exercise inappropriate. So doing some sort of total body movement assessment prior gives you an idea of not only what are they capable of doing at the area of interest, but as a whole, so that you know from an entry point for exercise, what's an easy area that you can intervene on day one, and you're not blindsided and scrambling later on in the session where maybe you may not have enough time to then switch gears and lateralize to a different area.
I think a big thing too is I think if you put yourself in the position of the patient, or person that you're working with, from a psychology standpoint, they almost feel like you're more invested in them because you're checking all of these other different boxes. You're deep diving. It's viewed to be a more comprehensive approach. So I think to a certain extent, in addition to you getting more information and probably better information to appropriately prescribe certain movements and exercises, you have an individual that almost appreciates the amount of things that you're looking at, and other conversations do pop up. And then you are, in addition to getting more information from a physical testing standpoint, you probably have more deep dive conversations in terms of an individual's like past medical history and stuff like that. One of the things that I would mention as well to this appraisal, and yes, it's a little bit more of a binary look at things, but you're familiar with special testing. There's plus and minus, right? You either have a positive test or a minus test, and then you have certain situations where we've written WNL, within normal limits. So keep in mind that with the top tier and then with some of the more isolated movements, you're looking at things in isolated situations, or even as the eval goes along, or let's say you have a higher level individual, it's more integrated. A push-up is something we're meeting a standard on or not. A regular squat is something we're meeting a standard on or not. I think we could all agree that people should be able to balance on one leg. And then you potentially get into even higher level movements with people as they go. It's a very, very easy way to kind of have general framework for your thoughts and decision making as your test-retest is something that you're doing in subsequent sessions. Do you have anything to add in terms of how maybe the SFMA or the framework of the SFMA then ties into things like your follow-up sessions as well as maybe even return to sport testing?
So, and I think even before getting into that, you mentioned the amount of information and the amount of conversation we can get into this with a patient. I don't want that to get confused with increased time either. So the individual I was speaking about the utilization of this in an eval, I had them take myself through this top tier of testing just to give them a real life example of how much time it should or shouldn't take. It took under 2.5 minutes for them to take me through this full movement screen prior to getting onto the table to then look at the actual area of interest. So it's a way to get a tremendous amount of information in a pretty short and quick amount of time that is relevant to your subsequent interventions or assessments, which I think actually segues into this very well, because a lot of the movements that we're looking at with this movement appraisal are things that we should either be able to do as a general population. We should be able to touch our toes. We should be able to rotate well. We should be able to reach behind our head and behind our back. So there are also ways that we can serve as just hitting what we would consider a certain demographic norms or different norms related to their age or their specific activity. But it also serves as another quick and informal way of doing a test-retest with somebody or giving them benchmarks for a home program. Hey, I know you're coming in here for your ankle, or I know you're coming in here for your hip, but remember when we asked you to reach down and touch the ground and you could barely get to your middle of your shins? Next time I see you, I would like for you to be able to get your shoelaces, or I'd like for you to be able to get to the ground. If you can do that, it opens the amount of exercises that we can access that are relevant to your ankle or your back or your hip tenfold, and we can get more bang for our buck for that. So I think a lot of times it fills in those gaps of you're trying to connect the dots with the patient, and either you're struggling to articulate that, or you're intuitively doing it, you're just not expressing it to in a manner that they pick up. A lot of times this total body movement assess, it helps connect the dots between performance and wellness, or general and specific activities, and how they integrate.
And just to kind of close this, I would mention that you are checking for competency, right? People meeting an expectation before developing capacity. So that goes along with everything that we're focused on in terms of return to activity, return to sport, post-op, acute situations. We restore isolated competency. We start to refine more of our integrated competencies. And then through later stages, when we're prepare and perform, we're focusing on capacity in the areas of which we've achieved competency. So hopefully that helps. And as always, with any of these videos, don't hesitate to reach out to Zach, myself, or any of the more veteran clinics or veteran clinicians at your respective offices.